Thanks for reconvening. I'm Andrew Bernard. I'm the trauma director, chief of trauma here. It's my pleasure to introduce this year's Schwartz lecturer, Maggie Griffen. Maggie is a native of Lexington, went to Lexington Catholic, was a center at Lexington Catholic, which I learned last night. Basketball star there.
We were a short team.
Graduated, went to Wittenberg for undergrad, and then was a teacher in Montessori school for a few years before returning here to go to medical school. She was a couple of years ahead of me in medical school, and then did her general surgery residency here. So she was a resident when I was a student. She was a resident when I was a resident. And then she was a fellow when I was a resident. And all along the way, she taught me, she counseled me when I needed to be counseled. Maggie, of course, growing up here as a medical student and a resident, was trained by Richard Schwartz. So like so many people in the room, there's a little Richard in Maggie. There's a little Richard in all of us. So I've got Richard in me, and I have Maggie Griffen in me. Maggie finished her fellowship here. She was the first critical care fellow, which was really special, not just to be the first, but when she was interested in critical care, and the trauma director and program director then, Paul Carney, wanted her to be his first fellow, he allowed her to submit the application for the fellowship, which was a big opportunity for you.
Yeah.
So right off the bat, you learned how to become a program director when you were just a fellow. So Maggie left here, went to Jacksonville, University of Florida, Jacksonville, for her first trauma faculty job for 6 years. And she's been the trauma director and a faculty member at Inova in Fairfax, Virginia for 12 years. Maggie's obviously an accomplished surgeon. She's an incredible team leader. You saw one of her references today and the work that she does there. We had a great time making rounds this morning, having Maggie make trauma rounds with us. Maggie was always the person that we could go to for help. The nurses always trusted her because she responded and she took care of things. She's been an incredible mentor for so many people here in Florida, in Inova. She's left an incredible legacy, and I think one of the things that Maggie said on rounds this morning was most telling about her, and that was that she said, if you listen to the patient and you can focus on what's bothering them and what they're interested in, then you're going to be a great physician on top of everything else. So it's my pleasure to welcome Maggie as the 6th Schwartz lecturer. Maggie, and to have so many of your family members here, your brother and your parents here. It's just a great opportunity. Thanks for being here.
All right, I made him do that. All right, so I really can't, it's kind of a weird thing for me to be up here right now. I'll tell you that up front, so, because this is not where I ever see myself being, and I certainly 20 years ago wouldn't have said I would be back here doing this, but I appreciate Janet and Andrew and Dr. Sloan inviting me back, and I really appreciate everybody showing up. I'm going to try to cover in the next little bit here some stuff. It was always pounded into our head by various people in the trauma world that it's a young person's illness, it's young people, and it's not that that has changed, but it certainly is not just for the young anymore, and elderly trauma is becoming a greater and greater thing for our society as a whole, and something that we have to recognize. So when I think about how to make a lecture work, and Dr. Schwartz would not like the lecture, but I'm going to make it work anyway, or try to. I like the idea that it teaches you something new, hopefully. Hopefully it's a little bit interesting. That is part of it. I'm hoping to provide you some evidence for best practices and why we're doing the things that we do in medicine, since that should be part of why we do it. We don't make it up, although sometimes you have to make it up as you go along. Hopefully provide some examples of how to do it so that you can take that back to your world and apply it to your patients and make them better. And then maybe some stories along the way that might be funny or interesting. I do have to say a couple words about Dr. Schwartz, because Andrew's right, there's a little Schwartz in me. So the thing about Dr. Schwartz is that I had a unique perspective when I came here as a medical student, because I'd met Dr. Schwartz 10 years before when I'm sure I was an extremely pleasant teenager. Because my father was here and Dr. Schwartz came to train with my dad. And they would have a picnic every summer before the year started, and I always played basketball with all the residents. So I knew all of the residents long before I came here. So when I came in as a medical student, I had Dr. Schwartz here. He got to do a couple of things. One, and it was interesting when I had lunch with the senior residents and we talked about the fact that we didn't have cell phones back then. Yeah, it was 30 years ago when I started medical school, believe it or not. So there were no cell phones. And one of the comments at lunch was, how do they find anybody when you didn't have cell phones? And, well, you had pagers when you were a resident. We had little pagers, and all it came was a number. But before you were a resident, you were a medical student, and you're right, nobody could find you. So unfortunately, I was a medical student here when my grandmother died, and you couldn't find me. So my parents found Dr. Schwartz, and Dr. Schwartz found me. And yeah, I know, I remembered that when I was thinking about this talk. So the other thing that he got the dubious honor of doing was listening to my mother as I was going through medical school. No, Rich, I don't think she should be a surgeon. No, Rich, but if she's going to go into surgery, she really shouldn't be a trauma surgeon. I don't think that would be good. And bottom line is they both failed, and that's not what happened. He tried, but that's not what happened. So I could never thank him enough for just being a friendly face and a support throughout what is a stressful time for all of us, certainly. So what we'll try to do during this lecture is talk about something new by giving you the impact of trauma in the elderly and the impact to us as a society for trauma in the elderly. Talk about some evidence to support the best practices we currently have for injury prevention, some management strategies for the elderly, and then some how-to so that hopefully we can maybe move forward in that direction to help our patients. This is some of the Acute stories. So this is Sandy and I's latest additions to the family. This is Vincent, and that's Frida, and they're 4 weeks in the household, and the 12-year-old dog and the 16-year-old cat aren't quite sure what to do with themselves at this point, so we'll see how it goes. So the impact of trauma on elderly. So I don't know if you all know it, but when it comes to elderly, 65 and older in the world of trauma is considered an elderly person. Some of us, that's not so elderly anymore, but those are the rules and that's how it's defined, okay? Right now, there's about 40 million people in the United States that are considered elderly. It's going to be 70 million in another 10 years. It's going to be 80 million in another 20 years. So these are not small numbers of people, and they're not your grandmother's grandmother, right? I think about my grandmother, and I'm sure she was probably 60-something, and I thought she was 1,000. So the bottom line is it's an active population. They're out there doing a lot of things, and a lot more things than they used to do. Where do people die from injury? Well, they die everywhere in the United States from injury. Now, pick a good state. You want the dark blue. That's where you want to settle, okay? Kentucky's not so bad, I guess, sort of too far to the right. But these are the per 100,000 folks are dying, all right? So this is 1998, long time ago. Hopefully not before anybody in the room was born, but you never know. And you can see, this is 65 to 85, all right? Sooner or later, they're going to have to decide 85 plus is not enough to define these, and they're going to have to go to 95 plus. And you can see, unintentional injury. It's always been here for the 1 to 44, or 1 to 34. That's never changed. But here, it's 7 and 8, as far as causes of death in 1998. Less than 20 years later, this is 2017, we're up at 6 and 7. So it is becoming a more prevalent reason for the elderly patient to die, is from an unintentional injury. When you look at the CDC cause of data for 2016 and 2017, accidents, which really, I'm not sure why the CDC can't call them something other than accidents, but unintentional injuries is number 3. The percentage is low, but it's number 3, and intentional self-harm or suicide, which is something we as trauma folks get to deal with, is down there as well. So it's a growing problem in this country with regards to the elderly trauma patient. Again, you look at Unintentional injury, 25 to 44. There it is. It's always going to be there. And although the pieces of the pie down here are small, they're getting bigger and bigger and bigger on a yearly basis. And that is creating a problem. So if you read the definition for Medicare, so it's like we've got to figure out how much is this really costing us. So I'm going to use this a little bit as a surrogate, right? So Medicare, 65 and older, it's the health care. All right, so it'll give us some indication. Now there are some under 65 who get it, but we'll use it as a surrogate. This is the cost, overall cost for payers. And yeah, private insurance for overall healthcare costs. But when it comes to inpatient trauma costs by payer, Medicare is responsible for almost half of it. So it's not just the cost to the individuals and those people dying more frequently, being injured more frequently, but we as a society are paying for this more frequently. So what's the cost? Well, the fiscal impact to both the individual and a whole is huge. There's no way you can deny that. The national cost for trauma care, $37 billion a year. So if you don't believe that trauma is one of the major healthcare problems in this country today, it is. And the thing is that there's a lot of things we can do about it that are very simple and don't require a bunch of rats to die and 20 years for a drug to work. But we just don't do it. If you look at this within this $37 billion, Medicare is the highest burden. I just showed you that. And those over the age of 65 use 33% of all the healthcare dollars, with 25% of all the trauma monies being used by those over the age of 65. This is where we're spending a lot of our money. And even with knowing all of this, and it was coming, and we've heard for years, the elderly population is getting bigger, the older, they're getting more. We still never had a geriatric-specific trauma meeting until 4 years ago. Once again, we're behind the 8 ball a little bit. So, we know we have a problem. So how do they get hurt? Because if we know how they get hurt, right, then we can show that we can't do anything with this. So this is it again, right? So there we go. Unintentional injury, right? Our older folks. Well, how do they die? Well, they die because they fall. That's the number one reason. It's not a car crash. It's not somebody wielding a gun. It's that they fall. And when you talk about folks that are injured but that don't die, guess what? It's the same thing. They fall. Falls. Why are 90-year-olds on ladders? I just don't understand why they're on ladders. They can pay someone to cut the tree down. I swear. All right? They're falling and dying. That is what they're doing. Except that they're not falling from ladders. And they're not falling 25 feet from the construction site. They're having what we call ground level falls. Yes, I'm 5'2", and I walk about this fast, and I fall over, and I die 3 days later. That's what happens. So over 2 million visits for ground level falls, with 10 times more frequently in this population than you see in motor vehicle crashes. And 7% of these patients die. They're falling from standing. Really? Motor vehicle crashes still happen. They're increasingly happening in the elderly population because guess what? We have more people driving who are older. Pedestrian struck. When they get hit, they can't get across the street in the 39 seconds that's on the beeper. Okay? When they get hit, they're 1 in 5 chance that they're actually going to be killed by whatever happens to them. And violent assaults still account for 10%, even in this elderly population, for admissions to the hospital for trauma. And they're 5 times more likely that they're going to die from their injuries. This is my program, all right? So Fairfax, Virginia, if you don't know where it is, it's about 12 miles from Crazyland at the White House, or Washington, D.C. in general. And this is our 65 to 80-year-old, all right? 80% of what we see in this age range is falls. Now, most of them aren't injured very badly. For those of you, this is an injury severity score. Most of them are injured not very badly at all. And yet, look, they're still dying. When you get to the 81 plus, 93% of them we see because they fall. Not for anything else, they fall. This is not unique to my center. This is happening all across the country. That we have, for years now, had more falls than motor vehicle crashes at our center for several years. So, who falls? What are the risk factors, at what cost, and how do we prevent it? Because if falls are a big thing, then we should be doing something about it, right? I mean, I don't even need a new app on my phone, and I can manage to do something about this. In fact, I should take the app away and the phone away. So, a third of all patients 65 and older fall. By the time you get to age 80, it's 40%. And when you talk about falls, it's like, okay, so mom decided to move out of the house. She's not living by herself with 7 sets of stairs. She moved into a residential living facility. Guess what? 50% of these patients still come from a residential living facility. So it's not that they're not doing the things that you hope they'll do, which is get to a single level and all those kinds of things. They're still falling. Most of them are during daytime hours. Only 20% of them are at night when we all think everybody gets up to go to the bathroom and they don't turn on the light and they can't see well enough and down they go. These are all reasons why they fall. Okay? They're all reasons. But if you look at most of them, they're all things that we can do something about. It's not like a tornado came and blew through. It's not like, no, there's things that we can do about almost every one of these things to try to have an impact on something that's a major problem in society and for our elderly population at this time. So, other costs, non-financial. To the individual, about 40 to 60% of the time there's a major laceration. There's some sort of fracture, not to their vertebral body, but to an extremity somewhere, or there's a brain injury. So it's costing the individual in pain and suffering. The other component of it is that some of these people do live by themselves. And they're down on the ground, and it's 12 hours till somebody finds them. Family checks in, they're great, they're going to bed, they fall down. Family checks in the next morning, but it's 12 hours later and mom laid on the floor for 12 hours because nobody knew she was down and she couldn't get to a phone and there was no way to know it. So then we have to deal with the problem not only of what happened when the fall, but now she hasn't anything to eat or drink for 12 hours. She's been laying on that one arm for 12 hours and she comes in with rip-roaring rhabdo and hypovolemia and she's already way far behind the starting point. 95% of all hip fractures these days are a fall. 20% mortality at 12 months. That's better than it used to be. When I started as a resident, it was somewhere between 40 and 50% if you broke your hip. So we're doing better, but 95% of these people break their hip in the first place because they fall. The individual cost, again, is psychological. So often you hear the story about somebody who breaks their hip and then this happens and that happens and then down. Because what happens is you have somebody living independently at home, they break their hip, they can't go home, they have to go to an institution. They don't like the institution, so that bums them out. They can't get up and do what they used to do. Even if they weren't playing golf anymore, they walk down the street or they did whatever, and they lose their independence. And that ultimately leads to depression, which is a huge problem in the elderly that I don't even have time for. And then you get a downward spiral in their health. So it's just an ongoing problem that occurs. From a family perspective, what's the cost? Well, the cost is often guilt. I didn't have them in the right place, or I didn't pay enough for that, or I didn't check on them enough, or now I've got to do more and I can't afford to do more, so I feel bad about that. I don't have the capabilities to support them. I mean, it can go on and on and on. And in 2012, they did a singular study just looking at falls and the cost $30 billion alone just for falls. Not just for the act and in the hospital, but all the care and everything that goes around it. $30 billion for falls, which we can do something about. So what are our goals? Well, our goals are obviously to reduce the falls altogether. Get rid of them, try to alleviate them. I'm not goofy like the government. I don't believe that there's a capability to get to zero. But let's try to work on something. Reduce the injury when you get a fall, and then ultimately to maintain as much as independence as possible, because if you do that, it helps with the recovery for the patient. So it's simple, actually. I know, it's weird. 3 questions. You ask them 3 questions. So again, I don't have some high-tech piece of equipment that's going to cost an administrator $1 million to buy for me. I just have to ask them some questions. It starts by being a multidisciplinary team, which is probably one of the hardest things that we have to do because we've lost a lot of that in the medicine and the way it's fractured these days. But collaboration between what we do here in a hospital and what somebody does as an outpatient setting. In order to go through all of this to do an in-depth look into patients and try to help them out. And so a team in 2013 actually put out their data, the STEADY trial, which basically was an initiative to decrease the elderly falls, deaths, and disability problems that are going on in the United States. So it started with a similar kind of thing. Have you fallen in the past year? Do you feel unsteady? Do you worry about falling? If anything's over 4, then you start working through things. You give them a brochure that talks about all the things that you need to do for a fall. You get a multifactorial risk assessment. So they read that. You get their fall history, you do a physical, you decide about the labs they need. How many patients have hyponatremia and it's just not known? And you just treat it. You get a cognitive screening, you look at their medications because polypharmacy in medications is a huge issue. You look at their mobility aids, you figure out what they are, and you do a visual acuity check. These are things, I don't need my vision checked anymore. I'm old now, I already wear my glasses, right? Then you implement the process. You start educating the patient, you start working on their balance, you treat their medical issues, you look at their polypharmacy, you optimize their vision. So that ultimately you get a patient in an exercise program. I know, the 90-year-old in an exercise program, this seems silly. It's not silly, it's actually what they need. Kids, when they're little, you want to get them exercising to wear them out. Old folks, when they get old, you want to exercise them to wear them out, okay? Trust me on this. But at the same time, the added benefit is they're going to gain some strength. So an exercise program. And to monitor them. And now that's where some technology comes in. Because you can monitor them participating in the exercise program. Balance training. Again, medication review. Go home and look at their home. People don't know what at home might put them at risk for a fall. And then education for everyone with regards to the fall. So how do they get hurt? Or how badly do they get hurt when they're hurt? So just a little bit about ISS. It's not perfect. I'm not going to tell you it's perfect. Nothing's perfect in the world. If you haven't learned that by now, sorry. Anyway, so there's a lot of injuries, okay? And what happens is someone gets scored in this injury, and then it gets multiplied by 3, and then they come down here, all right? So they're minor if they're 1 to 8 or 0 to 9. Anybody over 16, the number 16 is somebody we consider to be significantly injured. All right. So in general, the elderly have a higher mortality and poorer functional recovery than their younger counterparts. If they're minimally injured, so an ISS of 0 to 9, they may have a 3-fold increase in morbidity and a 5-fold increase in mortality. But somebody who has an ISS greater than 16 may only have a 2-fold increase in morbidity and a 4-fold. So we're doing better with the more significantly hurt? Why are we doing that? I'll answer that in a little bit. Mortality with brain injury is about 40%, so very high. And failure to regain their functional capabilities can be as high as 30% or more. So again, we're talking about these issues continue with the elderly. So why is minor so bad? Well, the reason minor is so bad is because of the impact of aging. So I came here in June, and after wandering around completely lost for a while, I found the back hallway, and I took a couple pictures. So I will say one word, and that's me. So I have aged. There's no gray hair there, and hopefully you can't see much of it today, but it's there. That's Dr. Roth, who, wait, he has hair. So that's one. And it's dark hair, so. And then Dr. Bernard over there, who I don't know that he's he's aged as much as some of the rest of us, but he and I both discovered product, so that's good. I will say, for those of you who are residents, hang out with your fellow residents. So these are a group of residents too. That's my dad. You can see where his loyalty lies. That's my mom. These guys all became residents in 1950-something. And everybody in this picture today is still alive. Everyone's over 90. My mom will correct me if I'm wrong, except for Mrs. Gott, right? This is a guy named Vincent Gott, and if any of you have heard of the Gott shunt, that's the man. And this is Harlan David Root, and if you've ever heard of the DPL, that's him. So that's who I grew up with. No pressure. But, and this gentleman is a world-renowned pediatric ID specialist who's 95 and still travels the globe giving lectures. So, and they still meet when they can, although it's a little hard these days with everybody over 90. This was at our house a few years ago, and they all managed to come by. So it was an interesting evening. All right, so what's the impact of aging? Well, neurologically, you get these cognitive impairments as you get older. And trust me, there's words I'd love to know right now that I cannot remember some days. Visual impairment, you don't have as good a balance. Your strength's not as good. It just comes with aging. From a cardiac perspective, okay, you're going to take the 90-year-old and they're going to be stressed and you're going to expect their 90-year-old heart to do the same thing the 20-year-old heart does. It just doesn't work that way. From a pulmonary perspective, pulmonary disease in and of itself is the third leading cause of death in the elderly population. So when you compound that with some sort of injury, you're asking like for greatness here, all right? Renal perspective, by the time you're 70, you could have lost as much as 50% of your function. That can't be good when you get in your car wreck or you fall down the stairs. Malnutrition is huge. 40 to 50% of people who are admitted from a nursing home are malnourished. You gotta fight that. And then musculoskeletal, bone density, joint flexibility, all of that stuff. Just muscle mass loss in general is all there. These are things we can do some things about, but some of it's going to happen no matter what. 80% of all geriatric patients show up with at least one, if not more, chronic diseases. So now we're not talking about the 25-year-old who hadn't been to the doctor since they graduated from high school because they don't need a doctor and they're all good. You're talking about somebody who probably goes to the doctor every month and it still doesn't matter. And they have all these things that you got to deal with. So how do we care for them? Well, this is what we do now. We treat them like everybody else, right? You send them to the hospital. They may get to a trauma center. They may go somewhere where they get an ATLS evaluation and follow some standards of trauma. You may have a plan to admit them or discharge them. You may have to operate on them, and then you send them home. I mean, that's what you do. It's just like every other patient. You just, right? But that's the problem. One size doesn't fit all. So these are sort of the standard things that we use to activate somebody at my place for a high-level activation. And we would all agree. Those all make sense, and they should happen, right? Somebody who's in a coma, somebody whose blood pressure's low, heaven forbid, their leg cut off, some whatever goofy stuff that happened. The problem is that geriatric patients are routinely under-triaged. They just are. They get sent to the local hospital because they just fell from standing in their bedroom and they want to go to the local hospital and somebody looks at them and they're fine. Only they may not be fine is the problem. So they never get sent to a trauma center and they never get fully evaluated. Those impact of aging things that happen, the problem is 90 is no longer a good thing. So yeah, a 20-year-old, a 30-year-old can handle with blood pressure less than 90, a heart rate greater than 130 maybe. But you see those kind of things before you're activating somebody who's 90, you're off. you need to be starting that systolic blood pressure at 110 or 100, and you need to be starting with a heart rate of 90 in those patients in order to make them an activation. When it comes to neurologic, and this is one of the things I talk to EMS about all the time, because one of our activation criteria for our non-high level is a GCS of 13. Well, there's some old folks that have a GCS of 13 when they're sitting up and, eating breakfast. I mean, this is part of the problem. So they always say, well, we never know, because they tell us they have dementia, and we don't know whether they're altered more because of what happened or not. And so they go to the local hospital, and they get seen. And they don't get to a trauma center because it's their baseline. Or they have anticoagulation problems, and we've all run into this. And now, thank goodness, somebody invented some new anticoagulation things that we could all have. And so they become an issue. And who's on them, and how much are they on, and did they take them, and how do we make sure we take care of that in the face of trauma? So what you have to do, and what we've done recently, is we have elderly-specific criteria. So somebody over the age of 70 who has a blood pressure of less than 110 or a heart rate greater than 90 gets to be in activation. Not our highest level, but they get to be in activation. And by helping our EMS colleagues understand that, hoping that they're going to bring us those patients as opposed to one of the other hospitals. We also, for anybody over 70 who's anticoagulated, and why 70 and not 65? Because if you look at the literature, which isn't great yet, that's the number where the cutoff starts to come. And so if they're anticoagulated and they have any of these things, ground level fall with an altered level of consciousness and they're on warfarin, they should be in activation and they should be seen by a trauma team to make sure we're not missing it. So this is where we get into wanting to not under-triage these patients. So how do we care for them? Well, that's the hard part. So we have all those things about impact of aging, but we don't know who has what. So we've tried to come up with frailty scales. Frailty is a big thing. We've tried to come up with it in trauma. The problem is most frailty scores that you have to try to figure out, you hold up the booklet that's about 17 pages long and you start on page 1 and say, what did you have for breakfast? And how did you eat that breakfast? And you can't do that in a trauma setting. And you can't do that with these patients a lot. So there was a group that came up with about a 15-point, as objective as possible set of items to come up with a frailty score that would be a little more down and dirty to be used in the trauma patient. It hasn't had a lot of time to sort of marinate and grow, but we're hoping the time is going to come so that putting that frailty score with that ISS score, with what we're seeing, maybe we can come up with some better algorithms. For traumatic brain injury, 80,000 visits for the elderly, over 2 million in general for trauma, all right? 1 month mortality is 40%. Not regaining function, as I said, is high. Increased disability and potentially mortality with risk of anticoagulation, although you can get papers on both sides. But the East guidelines in 2012 even said someone who has a severe brain injury, is comatose, is an elderly patient, by 72 hours, if they aren't getting any better, you really should start to be having conversations about limiting therapeutic interventions. Not spending another 3 or 4 weeks doing whatever you're going to do to try to figure out what's next. So just a couple stories. So I did throw in some stories for Dr. Schwartz. So this is a 74-year-old that we saw. A little bit of subarachnoid hemorrhage here. 34-year-old with a fall and some subarachnoid hemorrhage here. So the 34-year-old, he got worse. He got decidedly worse in 24 hours. Had a subdural that showed up, got a cranie, was in the hospital a couple weeks and went home. The 74-year-old, she did great. She lived at home before this, so she came to the hospital. Well, we couldn't quite get her home. We had to discharge her to a facility, but we got her to a nursing care facility, and within that 30-day time frame, she came back to the hospital having seizures and died in hospice care within 30 days. And her brain injury never got worse than this right here with a little bit of subarachnoid hemorrhage. So the problem is you got to be a little bit aggressive. These patients that are elderly need to get in the ICU so you can watch them. You need to be liberal about your imaging. Don't be afraid. They're not like the kids where you got to worry about how much radiation you're giving them. It's okay. Reverse their anticoagulants. Whether your facility has FFP or PCC or whatever it is, reverse it. and then get them moving as soon as possible. And then you've got to pay attention to monitoring and management of delirium, which unfortunately is another whole topic that we could talk about in the elderly patient who comes into the hospital. When you talk about thoracic trauma, it accounts for really a quarter of all the patients who die that are elderly with trauma. Rib fractures. It's terrible. And you think, oh, it's not too bad. Well, if you never had them, then you probably think they're maybe not too bad. But if 3 to 4 rib fractures in an elderly patient occur, they've got a 30% risk of pneumonia. They have a 30% risk of mortality. And if you get to 6 ribs, they've got a 50% chance of getting pneumonia. And solid organ injuries are much more common in this patient population. So you have to be aggressive with these folks. So again, this is an 82-year-old, that's Ms. Lowe, who fell, broke his ribs over here, and a 42-year-old that broke his ribs over here. So the 42-year-old, he went to the regular ward. He was just out on the ward. We got some oral pain medicine going. He got a couple doses of IV stuff, but within 24 hours, he was up walking the hallways, doing 1500s on his incentive spirometer, ready to go home. The 82-year-old went to the intensive care unit because we have an algorithm in our facility that if you're at a certain age with a certain number of rib fractures and any comorbidities, and he had some COPD, you go to a different place. So he went to the ICU, and we were fairly aggressive with him. Not only did we do oral medication and IV, but then we have to worry about delirium, but we went catheter-based therapy and got a rib block and did all kinds of things, got him up moving, and thankfully he got out of the hospital. 6 days instead of 24 hours, but we got him out. But we've had just as many who went on to have respiratory decompensation, and then depending on their age and their goals of care, they don't want to be intubated. And this ends up being the end of their life and their terminal event. So, pain management is key, and in the elderly, our problem with pain management is always how do we do it and not have them get delirious. So you have to think outside the box with them sometimes. Pulmonary toileting, it's a simple thing. It costs like 3 cents to make, I'm sure. I'm sure we pay $75 for it, but it costs 3 cents to make. It's a little incentive spirometer. It's not, you know. And then operative fixation of the fractures if need be. More and more we're doing some of this if they meet criteria to have it done. Orthopedic injuries are huge, all right? 127 hospitals looked and said, hey, how many geriatric patients are we admitting with orthopedic injuries? 25,000. 50,000 of those patients had to have a major operative procedure, right? So 12,500 operations in just those 127 hospitals that they looked at. Significant amount of injury in the elderly population. And unfortunately, a lot of it is this stuff. I had my hip replaced 20 years ago. Now I broke my leg down here. Oh, great. Even better. The orthopods love that stuff, right? It's terrible. So, early definitive repair. You have to have a place, and the patients need to be in a place where they're not going to lay somewhere for 3 or 4 days before they get fixed, where they're going to be in the operating room as soon as possible so that you can avoid a complication, reduce their mortality, get them mobilizing so you avoid the pneumonia and the breakdown. You got to be in a place that's capable of doing that and has those resources. And finally, where do we miss? Well, these are places where we miss all the time with elderly trauma. They fail non-operative management more than other folks. But guess what? We're probably pretty squeamish about operating on them sooner. And then we just cause more trouble. The normal vital signs, right? Oh, they came in, they had normal vital signs, as one of my old attendings said. What is normal? I'm not sure. They had normal vital signs. Well, 50% of people who come in, elderly trauma victims who have normal vital signs, die. So we're missing something there. We don't put them in the right place. Elderly patients in general have a lower ICU admission rate. That seems odd in ways. And then delirium, as I said, could be an entire other talk. It's much more prevalent in the elderly. We have no choice but to provide treatment for them in a variety of ways, but they're much more likely to develop delirium. It increased their hospital course. It isn't just affect them while they're in the hospital, it affects them for a year, and it adds tremendous amount of money and cost to what we do. So, The other component of elderly trauma that you have to understand is that, the focus for us is always, okay, we're going to save them, we're going to save them, we're going to save them. And survival, no doubt, is what we want. But we also have to think about functional recovery. We have to think about maintaining their independence. We have to think about whether these folks are going to have the ability to go back and age in place. It's a big deal. It may not seem like a big deal for you, but it's a big deal for them. And then support them if their decision is that they want to be comfortable and they want to have their goals of care met, which will ultimately result in their death. You have to support them in that and support their family in that and know how to do that. So you have to do an assessment. So if you're going to talk to a family about those kinds of things, then you have to have a tool that you can use to assess who's the patient that I need to be saying, you know what, Grandma's probably not going to make it through this, or Grandma's likelihood of making it through this is X. So this is a group in 2012 put this out and basically looked at certain injuries and what medical history indicators they had, and then sort of an assessment indicators to try to figure out, could they put someone in a high-risk category, what they call the geriatric high-risk patient information. And if someone met these criteria and went into that high-risk category, then they got this. They got put in this standard kind of thing. We're going to do this regularly. We're going to do this. We're going to do this. If they do this, we're going to do X. All right? That's the plan. And what did they do? Well, they basically made a difference. They shortened the length of stay. They had a trend towards improved mortality. So they felt like by putting them on a standard trajectory, and we're big in trauma on guidelines and protocols and pathways. We've always been big on it. I had them beat into my head here. Okay, so it's not something new to us. We just have to change the dynamic so we make it specific to the elderly patient. Also in 2012, a publication came out from a level 2 trauma center. They had what they called a dedicated G60 unit. And I have to say, whenever I say the G60 unit, I can only see old people in tracksuits with gold chains around their neck dancing. But that's what they called it, the G60 unit. And they essentially, upon activation of a trauma, would have these patients, them come in. There'd be a trauma team there, and we would direct traffic and we would admit the patient. But then there was a hospitalist, a rehab physician, social worker, pharmacy, palliative care, nursing specialist, PTOT, and nutrition that all were part of that team. And they saw that patient in that G60 unit within the first couple of hours of them being in the hospital. And the reason was to get them ready for whatever it was they needed next. So there was a set of expectations for the unit, and they did quality review about those expectations. And what did they find? Well, they found that they shortened their time in the ER, they shortened their time to the OR because the hospitalist was right there, and if an anesthesiologist or an orthopod was wanting to know were they okay to go to the operating room, they wouldn't take it from the trauma surgeon, but they'd take it from the hospitalist. They decreased their ICU length of stay, their hospital length of stay, they lowered their urinary tract infection, and they lowered their mortality. And they have a specific location in their hospital for the elderly trauma patient. There was a group in 2014 did the same thing, only this was at a level 1 center. Same idea. You can see all the people involved. These were all the people involved in this sort of trauma, what they call the Geriatric Trauma Institute. And it was within their level 1 center they started the Geriatric Trauma Institute. They reduced length of stay. They showed a cost reduction because they had a lower length of stay. And again, a trend toward an impact on mortality. They just didn't have enough patients yet when they published this paper. Now, what's our problem with getting there, with getting to those units? Because I really believe that that's going to be something we need to do. And the problem is we don't have enough of us. There's not enough trauma surgeons. Most of us are located at a level 1 center at a big hospital, and whether we need to work on creating fingers out there in the world with smaller hospitals that have these programs. Geriatrics is huge. It's great. If you want to go pick a field to go into where you're going to have the pick of how much they're going to pay you, geriatrics is the thing to go into right now, because by 2030 there's going to be 1 for every 4,200 patients. And the elderly is only increasing. And if you don't use a geriatric team and you use a palliative care team, you run into the same problem, in that there aren't enough palliative care physicians out there. So from a workforce perspective, we're going to be limited in moving forward with that type of care plan. But the bottom line is we have to have a lower threshold for these patients to get to trauma centers. And that's going to require cooperative effort with our other hospitals and our EMS personnel. Routine CT use should be liberalized, and it's definitely for anybody who's fallen and had any kind of bonk to their head and is on an anticoagulant. You have to know about pre-injury anticoagulation, and you can't be afraid to reverse it because they have worse outcomes on the short-term basis. You have to review their polypharmacy. I know it's what all surgeons like to do, is look at how many drugs their patients are taking. But having said all of that, you can't let age alone be something that causes you to withhold treatment from a patient. So how do we go about trying to be successful? Well, we ensure, as I said, the appropriate facility. We ensure that people have knowledge of the physiologic changes that go with aging, so we understand how that heart rate of 110 in the 100-year-old is bad compared to it in the 35-year-old. We adjust our treatment algorithm so that the 20-year-old with the femur fracture isn't being treated the same as the elderly patient. We get our geriatric specific activation criteria. We work to create these specific units potentially. And then one of the hardest parts, I think, is going to be is collaborating with an outpatient sort of team, whoever the patient's team is if they have one, on ongoing interventions and prevention for the patients. So how are we going to do this? Well, we have to maximize our injury prevention. We spend a lot of time in injury prevention talking to kids, parents, and all that kind of stuff. And I'm not saying stop that in any way, shape, or form, but there are a lot of geriatric programs out there that in most injury prevention programs are not the highlight of what they do. The specialized activation criteria, we need more data. We don't know exactly what makes the right combination of things to activate. So right now we're all sort of changing things up and seeing what we get and hoping that we're getting to that sweet spot of the right amount of under triage and the right amount of over triage. We have to get our management guidelines more specific to avoid that less than treatment. And there are guidelines out there that have shown they work, and they identify things sooner, and they lower the length of stay, and they lower the mortality in these folks. And then you have to have a collaborative team approach. I really think that. At our center, we call the geriatrics people on everybody 80 and older. And I'll be honest, why is it 80 and older? It's because that's all we can have them do because their workforce, if we call them for everybody 65 and older, they'd never be able to see all our patients. So we've instituted it that it's an automatic for anybody 80 and over, and anybody 65 to 80, if we think it's somebody that could benefit from their consultation, we get them involved. And they spend a lot of time doing a lot of the things that we don't have the time to do with these families and with the patient, to get them ready and communicate with their outpatient physician in order to come up with a plan. So it benefits you significantly. And then education for everybody with regards to having those really quality of life and goals of care discussions is a priority that we all have to start doing a better job with. They're not comfortable conversations. Nobody likes doing them. You don't like having them in your own family. But if you don't do these things and we don't help everybody learn how to do them, we're just going to continue in the same vein that we have till now. So I'll tell you my own sort of story about geriatric trauma. That's my parents. They're over there. So my mom, the shoes and the surface didn't like each other. So in the winter, my mom and dad come live with Sandy and I in Virginia because you winter in Virginia. When you're in northern Michigan, you winter in Virginia. So she went down from standing, okay? It was a good noise. So she dislocated her shoulder, and she broke her greater tuberosity. And after the local EMS folks arrived at my house and said, "Hey, doc, what's going on?" I said, my mom. We got to the hospital, and it took a fairly large orthopedic resident quite a bit longer than he thought it was going to take for him to put a 90-year-old's shoulder back in place. But he ultimately got it in place. And she had this little fracture, which we were hoping wasn't going to need surgery. But 2 weeks later, We were in the operating room, and she was at 90 having her surgery to fix her shoulder. And she spent then many, many months and thankfully has done very well and can now get her arm above her head and has recovered. But I will tell you, witnessing the psychological recovery, the sleep deprivation, trying to manage the pain was a significant problem. And it was a big issue, and I sort of should know what I'm doing, and this was a big deal. So it's something that's major to this world today, and it's something we need to pay attention to. So this one never gets old for me, being an old UK fan. I don't know that we're going to be successful in football this year, but it just never gets old to me. So I can't thank you all enough for asking me to come. It's been an honor to be here, and I thank everybody for your attention today. Thanks.